blood transfusions can save lives. Approximately 32,000 units of packed red blood cells might be transfused on any given day in the United States. Two main complications that can happen with transfusions are 1. Reactions, or 2. Transmission of blood-borne diseases such as hepatitis or syphilis. Transmission of HIV is quite rare but still possible, 1 in 2 million. Although all donated or allogenic blood is screened carefully, there are still risks involved. The preference is to seek alternatives to allogenic transfusion and to transfuse donated blood only when totally necessary. Blood is always in short supply, especially O negative, which can be transfused into anyone. Before transfusion, all patients must be notified of alternatives. This law, called the Gann Act, came into practice in 1990. Paul Gann died of AIDS in 1987 because of a transfusion that contained the virus. Patients must receive information about alternatives and sign a consent form prior to transfusion. Screening for HIV began in the mid-80s, and screening for hepatitis C began in the early 1990s. Here is a picture of Ms. Dorothy Sims, who had a left total knee replacement this morning. She is now dizzy, pale, hypotensive, and tachycardic. A CBC is drawn, and she has a hemoglobin of 9 grams per deciliter and a hematocrit of 25%. Prior to her planned knee replacement, Dorothy deposited her own blood in the blood bank. Now that she has had surgery and the signs and symptoms of a decreased cardiac output, what would you do? You need to report Dorothy's signs and symptoms to the primary care provider and anticipate an order for autologous transfusion, meaning give Dorothy her own blood back. Everybody has a blood type, and the type is determined by the antigens on the surface of the red cells. There are many kinds of antigens on the surface of red blood cells, and most don't cause problems during or after transfusion. At this time, some 32 blood groups have been identified. However, the primary concerns are for the ABO and Rh antigens. The immune system makes antibodies for the other types. For example, Ms. Dorothy Sims has the A antigen on her red blood cells. She is considered to have type A blood. Therefore, Dorothy's plasma contains antibodies against the B antigen. So what would happen if someone made a mistake and gave Dorothy type B blood? The answer is the B antigens on the cells of the donated blood when they entered Dorothy's bloodstream would be viewed as invaders. Antibodies in Dorothy's plasma would immediately go on attack. There would be clumps of transfused red cells as the anti-B antibodies attack the foreign red cells. This is called agglutination. These clumps lodge in the capillaries and can lead to circulatory collapse. Dorothy's system would launch a massive inflammatory response in an attempt to destroy all the B antigens that were mistakenly given to her. The inflammatory response, as you may remember, causes vasodilation and can lead to massive shifts of fluid from the intravascular to the interstitial space as all the capillaries become somewhat leaky, as well as bronchoconstriction. So how long do you think Dorothy can survive under these circumstances without intervention? Much of the population has type O blood. This blood has no antigens on its surface, and it makes antibodies to both A and B. What would happen if type A blood were given to a type O recipient? Again, the answer is that the anti-A antibodies would go on the attack against the A antigens. A small portion of the population has AB blood, with type A and type B antigens on the cell surface, and no antibodies in the plasma. So who can get what? The lucky few AB types can get A, B, or O. The generous many O blood types can only get O. Anyone can receive O blood type. So AB is the universal recipient, and O is the universal donor. The rhesus factor, discovered in the 1940s and named after the rhesus monkey, is present in most people, approximately 85% of the population. The Rh factor is represented by a D antigen on the surface of the red blood cell. A person with the D antigen, which is most of us, is called Rh positive. Can a person who has no D antigen, which is Rh negative, receive Rh positive blood? And answer, only if it's a life and death situation and there are no other choices. So, for example, let's say that Dorothy has type A negative blood. She receives A positive blood because of a major error in cross-checking the blood types. As she is receiving this Rh positive blood, she'll be okay for a while. There are no antibodies in her plasma against the D antigen. After she receives about 200 mL of the bad blood, her immune system will begin to recognize that there is an imposter, which is the D antigen, and will begin to make antibodies. So the difference is that with ABO, the antibodies already exist. With Rh, it takes a little while for the antibodies to form. So Dorothy would probably survive her Rh misadventure, but what if she gets another unit of A positive blood? The most serious kind of reaction is called a hemolytic reaction, which occurs when the patient receives an incompatible blood type. It's caused almost exclusively by mistakes made by the lab or nursing personnel. The antigens stimulate the antibody response and cells will agglutinate or clump together. We can determine our own blood type by mixing a blood sample with all the blood types and looking for agglutination. For example, A positive blood that you draw from yourself would clump if you mixed it with type B. Or if you are type O, it would clump if you mixed it with A or B. If you are type AB, it would not clump with any blood type. If a person were inadvertently to receive the wrong blood type, signs and symptoms would occur almost immediately. These signs and symptoms include burning at the vein, lumbar pain, chest pain, chills, and fever. These signs and symptoms are a result of a severe immune response along with the cell clumping, which leads to poor organ perfusion. Nurses are the last line of defense for preventing hemolytic reactions. Prevention includes checking units of blood at the bedside with a second licensed person, such as a doctor, registered nurse, or IV certified LVN. Initial vitals before administration. So can anybody think why you would take vitals first? Starting the transfusion slowly, observing the patient for the first 15 minutes of the transfusion, and checking the vital signs 15 minutes after the transfusion has begun. When a blood sample is first drawn for type and cross-matching, you can imagine just how important proper labeling of that blood sample is. The blood bank will not accept samples drawn from a nurse unless it's properly labeled and signed. For slide 5, the answer is O negative. That's because the patient is A negative, and type A blood can only receive type A or type O blood, and being Rh negative, that patient can only receive Rh negative blood. Therefore, the answer is, based on the slide, answer is B, type O negative. Therefore, in a life or death situation with no other choice, A positive could be given one time with the consequence that antibodies would begin to build up against the D antigens, which would cause an Rh reaction in the future. When someone with no D antigen, therefore Rh negative, gets a D antigen, antibodies will build up and that person is then sensitized. If that person gets a future transfusion with the D antigen, it will be more serious. What about the situation where the mother is Rh negative and has an Rh positive baby in utero? This situation will cause no harm to the first baby. The mother will receive some of the D antigen from her unborn child, and the mother will begin to make antibodies to this D antigen. No problem until the next pregnancy. So what if the next unborn baby is also Rh positive. Now the mother's anti-D antibodies that were made by the first pregnancy would attack the unborn second baby. Erythroblastosis fetalis, or hemolytic disease of the newborn, could develop if an Rh negative mother is carrying an Rh positive baby and has not been treated during her first pregnancy. Rh immune globulin, RhoGAM, is given to Rh negative mothers to prevent the mother from making antibodies against the D antigen. This is different from what happens with the chickenpox vaccine, where the injected person is actually getting a minute amount of weakened chickenpox virus. In this case, the vaccine triggers an immune response, but due to the weakened virus, there are few symptoms while the antibodies are created. With RhoGAM, the goal is to prevent the immune response and stop the immune system from mounting a defense. RhoGAM works by removing the antigen so mom's immune system doesn't respond. RhoGAM is given at 28 weeks of pregnancy and after the baby is born. RhoGAM is also given to women who have had medical or spontaneous abortions. Before receiving allogenic blood, that is, blood donated by a random person, everyone gets screened. Everyone should also be typed and cross-matched except in an emergency. Blood should not be transfused unless a type, screen, and cross-match has been conducted in the last 72 hours. So let's say that the provider just gave you an order to transfuse random donor blood for Ms. Dorothy. You call the blood bank to see if there is any blood available for Dorothy. The blood bank staff tells you that the clot has expired. This means that it's been more than 72 hours since a type, screen, and cross-match has been conducted. You have to get another blood sample from Dorothy before proceeding. You now have to get an order for this test again. Typing is done by testing the patient's red cells with antibodies A and B and looking for agglutination. Donor blood is tested for other antigens that could stimulate immune responses in the recipient. There are more than 500 other kinds of antigens to look for beyond A and B, but A and B are by far the most serious. Each unit is tested for transmissible diseases. So the steps: the ABO typing must be determined. The RH factor must be determined. The donor is screened for hepatitis, HIV, syphilis, West Nile virus, and specific antigens that could cause a reaction. The recipient's blood is screened for specific antibodies. The cross-match, blood from the recipient and the donor, are mixed and incubated. If a donor's blood and recipient's blood can get along together while sitting on a slide, then the blood is considered compatible. What if you're a kindly soul who understands the shortage of blood and wishes to donate your own blood at the church blood drive? You have O-negative blood type and are particularly worshipped by the blood bank. Most transfusions depend on homologous volunteer donors, but you must qualify in order to give blood. If you donate blood, you must wait 2 months before donating again. You must have a decent hemoglobin of at least 11 grams per deciliter and a hematocrit of 33%. You should weigh at least 110 pounds and have stable vital signs. What if you are expecting to have surgery soon? You can make an autologous donation, meaning that the blood you donated has been set aside for you to use when and if needed. With an autologous transfusion, alloimmunization, or reaction to antigens introduced by another person, is avoided. You cannot donate blood to yourself within 72 hours of the surgery. In preparation to donate blood to yourself, you would need to take iron supplements. You may want to be a designated donor and give your blood to a particular family member or friend, provided that your blood is compatible. Whole blood is rarely used. The problem with whole blood is that the platelets cannot be preserved as well. Also, the patient is receiving some of the bad stuff that is circulating in the plasma, such as ammonia and other metabolic byproducts. It is only used in extreme emergencies where the patient could benefit from all of the components. Packed red blood cells, PRBCs, are the most commonly given blood component. The usual reason for transfusing packed red blood cells is to improve oxygen carrying capacity. Hemoglobin can be raised by 1 gram per deciliter with each unit of blood. For example, from 9 grams per deciliter to 10 grams per deciliter. And the hematocrit can be raised by 3% with each unit. When transfusing PRBCs, it's ideal to transfuse blood through a larger gauge angiocath. A 22 gauge or even a 24 gauge could be used, but the blood flow will be slow. And if the blood can't get into the patient's bloodstream within 4 hours, the blood bank might have to split the units. You must use the PRBCs within 30 minutes after retrieving them from the blood bank. If you can't hang the blood within 30 minutes after collecting from the blood bank, then you need to return it, since you have now wasted too much time. When transfusing blood, you must run normal saline before and after. Packed red blood cells and saline are a marriage that cannot be broken. Packed red blood cells must be transfused with a 170 micron filter to catch any clots or large cells that form. Nowadays, PRBCs are generally washed to get rid of as many white blood cells as possible. This leukodepletion decreases the chance of a reaction. If the patient has a poor immune system, the PRBCs could be irradiated, which involves zapping all the white cells and rendering them inactive. This is a great preventative for graft versus host disease. So start the transfusion to run at 50 mL per hour for the first 15 minutes or follow facility protocol. Then turn up the rate to go anywhere from 75 to 200 mL per hour so that the blood transfuses between 1.5 and 4 hours. You must hang PRBC units with normal saline only and use Y tubing with 170 to 260 micron filters. Platelets are cell fragments that form plugs and stop bleeding, or hemostasis. Platelets are indicated for thrombocytopenia. It's very difficult to get enough platelets from one donor, and generally the adequate numbers must come from at least 10 donors pooled together. Platelets live up to 12 days. The normal platelet count is between 150,000 to 300,000. When the platelet count gets below 10,000, the patient is at risk for spontaneous bleeding and probably requires platelets. You can give platelets through a 170 micron filter, so use regular blood tubing. ABO compatibility is preferred, but since there is not much in the way of antigens on the platelets, you can get by with any blood type, especially if the red blood cells have been effectively removed with platelet pheresis. Plasma is the liquid portion of blood, and it's mostly water. There are no red blood cells in the plasma. Plasma is separated out and frozen, and it can last for up to 7 years. It's filled with coagulation factors, so we love to give it for liver failure patients who cannot metabolize proteins to make these clotting factors. It's also great for reversing the effects of warfarin, Coumadin. When transfusing plasma, RH is not a concern. For example, an RH-negative patient can receive RH-positive plasma because there is no D antigen in the plasma to trigger an immune response. There are no antigens in plasma to stimulate an immune response. There is a mild chance of a reaction if, for example, an A-positive person got B plasma, since there are antibodies in the plasma against the type A blood. So it's best to honor the ABO typing when giving plasma. Plasma can be delivered using a 22 gauge IV set, since there are no cells. For administration, use blood tubing with a 170 micron filter. Plasma protein, albumin, can be delivered with regular tubing. You can use any gauge since there are no cells. Cross-matching is not necessary either because there are no antigens or antibodies being delivered. It should be infused at a rate of 120 mL per hour, or half that rate if it's at a higher concentration. Albumin is used to draw fluid out of interstitial spaces and into the vascular space. It works well for patients with ascites and hypotension. An acute hemolytic reaction is usually related to clerical error and involves delivery of the wrong blood type. Clinical manifestations include burning along vein, flank and chest pain, and serious chills. Eventually, the patient suffers from circulatory collapse. With acute hemolytic reaction, the priority is to stop the blood transfusion stat and get some saline going in preparation for emergency treatment. Call the rapid response team. Hemolytic reactions are very rare, something like 1 in 600,000, but it's one of the most life-threatening types of reactions. With a febrile reaction, think flu-like symptoms, along with a temp. It's usually caused by a mild inflammatory response from the antigens on cells or white blood cells that are mixed into the unit of red blood cells. It involves an increase of at least 1 degree Celsius. When a febrile reaction is suspected, the transfusion may or may not be stopped. Alert the medical providers for orders. Oftentimes acetaminophen is ordered and the rate may or may not be slowed. Or there might be orders to hold the transfusion until the fever diminishes. It depends on the severity of the fever and how badly the patient needs the blood. This is a mild allergic reaction. This picture shows a patient with urticaria, also called hives, which represents a mild allergic reaction. What to do? Stop the blood and run saline. Keep watch over the patient and check vitals often. Of course, notify the provider. This picture shows angioedema, or swelling of the vessels in the tongue, which might occur with a severe allergic reaction that is about to progress to anaphylaxis. Anaphylaxis is the most serious form of allergic reaction, with signs and symptoms of serious hypotension and wheezing. What to do? Stop the transfusion. Disconnect the hub from the angiocath, start a saline infusion, call the rapid response team, and anticipate orders for antihistamines and life support. Other types of reactions. Graft versus host disease. What if a patient has a poor immune system? Someone with a normal immune response will be able to fight off the white blood cells that come in through the donated blood. But a person with a poor immune response, such as AIDS or a cancer patient, can't fight those invaders. The invading white cells will take over and start destroying normal tissue. The patient will need to have further immunosuppression. Irradiation might help prevent this kind of reaction. Next, circulatory overload. Blood products have a way of expanding intravascular volume in a major way. Watch out for patients who have poorly working hearts or kidneys. Elderly patients tend to have ineffective heart pumping action. These patients might need a slower transfusion, taking the entire 4 hours. Watch for heart failure and pulmonary edema with signs and symptoms like hypertension, abounding pulse, poor urine output, and dyspnea. Anticipate orders for furosemide, Lasix, and morphine for fluid overload. Disease transmission. The most common disease transmission is hepatitis C, manifest by anorexia, nausea, vomiting, dark urine, and jaundice. It usually occurs within 4 to 6 weeks following the transfusion. The incidence of transmission of human immunodeficiency virus, HIV, is rare since the routine donor testing was implemented in 1985.